Good morning, everyone. Welcome to New York, to the Mount Sinai Live Endovascular Live Case webcast, like we do every month. I am Karthik Guja, and I have with me Sadar Farhan.
Hello.
So we are here to welcome you for the case. I think just before going, PK, if I'm not wrong, we have crossed 100 cases.
Yeah, we're well over now, 103, I believe.
Yes.
Yep.
So we have successfully completed about 100 cases now. So, with all your support and everything, we've been doing continuously with complicated cases. PK again and Dr. Krishnan and Dr. Kapoor again have a very interesting case for us today. Before going live to the cath lab, I just want to remind you that the next live case webcast is on September 23rd. And the previous live cases have been archived into ccclivecases.com. So if you have any questions, we would love to hear them from you, and they will be promptly answered by Sardar Farhan here. So the questions can directly be diverted to him. I'm just kidding, just all of this. So,
Of course.
let's, without any delay, let's go to the cath lab here. Dr. Krishnan and Dr. Kapoor are waiting for us. Good morning, guys.
Well, thanks so much, Karthik, and that's a very nice introduction, and it really is a testament to our team and our fellows and the really the entire hard work that everybody's done that we've been able to get over 100 cases. As you know, Dr. Sharma started this before us and has reached, I think, well over 130 or 50 cases. I don't even want to misquote because he'll ask me why I misquoted. But it's a testament to online education. It's a testament to hard work and dedication towards education. So the other thing is I also want to thank all of you who've been sending questions. The questions have really gone up quite a bit in the last, I would say, month and a half from all over the world. There was one I shared with our current fellows as well as Dr. Sardar from India on a CLI case. Part of what we do here is to try to, collaborate in a global manner to be able to try and help. It's not that we have all the answers. We know there are a lot of great people doing a lot of great work out there, and I think the collaboration is the main reason we do this, and to try to come up with some sort of consensus in this confusing vascular world without a lot of data that's really concrete. So with that introduction, I want to introduce our team. To my right is Dr. Kapoor. All of you know him very well. He's the Director of Endovascular Interventions at Mount Sinai West, or Mount Sinai St. Luke's, excuse me. And right next to him is Raman Sharma. You met him in July. We're missing Sriya Avadani. She's on vacation, but these are our two endovascular fellows this year who've been doing an incredible job. Next to Raman is Michael Cryer. He's our interventional fellow who's been very, very interested in endo and has been doing a great job. Behind him is Elizabeth Holton, and then Damien are here to support the case. So we have a really interesting case that Vishal, I, and Raman picked out, and Sardar. This is a nice case because I think it brings up a lot of discussion points, and I think the point of today will be an algorithmic approach to a lesion that I think is very common in our practice. However, I think to come up with an algorithmic approach is going to be very, very difficult because we all have different ways of skinning the cat. So without further ado, I'm going to have Raman present the case, or Dr. Sharma present the case, and we'll go forward.
All right. So again, welcome to today's live case. And today, a very common case that we will see ourselves intervening upon is an SFA CTO. Next slide, please. So our patient today is a 55-year-old male. He was referred to Mount Sinai for ongoing bilateral lifestyle-limiting lower extremity claudication that was in the calves and feet that progressed to rest pain over the past 1 to 2 months. With a Rutherford class 4. And he reports bilateral symptoms. He has a pertinent medical history of diabetes. He's obese with hypertension, hyperlipidemia, current smoker, and depression, as well as some prior heroin use. And he's on a slew of medications, including metformin, some antipsychotics, and some Crestor, as well as methadone for his prior heroin use. Next slide. Before now, this is a two-part case because the first part has already happened, and he had an ABI that was performed at an outside hospital that showed both abnormal ABIs on the right and left, and a duplex was suggestive of a bilateral SFA disease. showing both monophasic waveforms in the SFA and ATA levels on the right, and a significant velocity drop in the proximal SFA. Next slide. He was here previously, just about a week or two ago, and at that time he was complaining of right greater than left symptoms, and he underwent right SFA CTO intervention using our pretty standard techniques. The lesion was intervened with a stiff glide wire with a navicross, and later with a distal filter placement, followed by atherectomy, DCB, and supera stent placement. There was some distal thrombus burden on the filter, which is then addressed with penumbra mechanical thrombectomy, and some distal embolization to the ATA, which was addressed with PTA as well as some atherotomy. Next slide. And these are the final pictures from the previous angiogram, showing the SFA CTO lesion that was treated both with the directional atherectomy, DCB, and the final supera stent placement. Next slide. And at the time when we did our initial runoff on the left side, we saw this long segment SFA lesion of the mid, roughly 15 or so centimeters, with diffusely collateralized vasculature in the SFA portion. Next slide. So, as we were saying, there's a lot of different teachings that we can speak about for SFA revascularization, and one of the first, we're going to do a lot more talking during the case as well, as far as Dr. Krishnan had mentioned about an algorithmic approach. But a few basics we're going to be going over right now will be access methods for lesion crossing, and then also just some basic information regarding the current therapies that are available. So as far as access, the considerations that have to be made are whether contralateral versus antegrade access would be appropriate or required, or would a retrograde reentry technique also be needed. And we'll talk more about that momentarily. As far as lesional crossing, there's you have true luminal crossing, you have subintimal crossing with reentry, our typical STAR method. And then we also have our re-entry devices, the Pioneer and Outback, as well as some crossing catheters for the true lumen that are also available. And finally, our DCBs and DES, BMS, self-expanding stents, and all the roles for atherectomy and filters we'll be getting into today. Next slide.
So let's stop here. That's a great introduction, Larman. That was a fantastic presentation of the initial stuff. Before we get to your lecture, I want to have Vishal go over the angiogram and then talk a little bit about what he sees, and then we can get to the questions to everybody.
Right. So as Raman talked about, they fixed the right side last time, and now we are aiming for the left SFA. So usually our approach, which PK will talk about as well, is to go on the contralateral side and go up and over. So we took the right common femoral axis. It was very favorable common femoral, not much degree of calcification, so that wasn't a limiting factor. This is an iliac shot again, not that bad. The tortuosity is not significant, neither is the calcification. So it's a very favorable arch for approaching in the up and over fashion technique. And this is our initial runoff, which we usually do. And here you'll see the degree, the extent, and the length of CTO and a distal runoff. I'm going to show you some DSA shots just to quantify the whole stuff. But before we do that, you can actually see there is good distal runoff with at least 2, maybe 2.5 vessel runoff with some diffuse PT disease. But essentially, the AT and peroneal and distal popliteal looks great. Going back proximally, we take pictures to define.
First?
Yep, sorry. Yeah, that's the foot. I apologize. Yeah.
So it's important again to see the foot, because if you do embolize, at least you know that the posterior tibial was occluded when you started.
Right. And also, if worst case scenario you have to come retrograde, you actually have to know where to stick and how your vessel, if it's healthy, at the foot region, the dorsalis pedis, and the distal AT region. And then we take our proximal DSA shots to define the anatomy. And here you can see proximally it looks okay. It's mainly the main the mid SFA segment, which has distal reconstitution via collaterals. You can see a big collateral coming laterally at the proximal segment, but this is a magged up shot, and this is one of the views.
So I think it's a good place to stop. Karthik, Sardar, Vishal, Raman. What do you guys think in terms of access points? How do you, let's go algorithmically the way Raman presented in his initial presentation. When do you decide retrograde up and over, antegrade, and pedal? Because as we all know, there's a big pedal, push to do pedal access for these kind of cases. So I'm just curious, Vishal, why don't we start with you, Vishal?
So for me, if it's a standardized case and we already know the anatomy from previous angiogram, and up and over here should be feasible, doable, and that's my personal to-go strategy as the first step. Of course, defining the anatomy. If it's a ostial flush lesion, then there might be an approach of up and over versus retrograde. But if it's a mid SFA CTO, then up and over is and the anatomy and the iliac arch is favorable. I usually go contralateral axis with up and over. My pedal primary first in this case is very limited and very restricted because I try to, for delivery of my devices, re-entry devices, if need be, it gives me more flexibility if I have a bigger lumen catheter, which I get access from the CFA. So for me, that's my to-go strategy. Here, if somebody wants to do an antegrade, you're not wrong because you have the anatomy defined, so you could do an antegrade access. But because it's mid SFA, I don't think there's a big difference between up and over versus antegrade, especially when you have to do pushability and your for delivery of devices. So for me, this should be just up and over.
Sardar, what about radial? I forgot to mention radial.
Radial is also now a big option, and many people are talking about it to reduce the risk of bleeding and hospital stay, and thereby also hospital costs. But the issue here is you need devices where you are able to push and have enough support. The question is, if you start with radial, you will have less number of devices which you can utilize for crossing this lesion. You are limited to some catheters, like the Navicross, for example. You have to use essentially the Terumo platform of devices are suitable for radial to peripheral, but it's for this case, I think, not the best approach to start with.
So, Karthik, one more question that's often been asked is what are some of the angiographic factors that you look at when you look at a CTO in order to make a decision on pedal access versus no pedal access?
PK, if you look at this angiogram, particularly per se, right? We always talk about CTOs, like, you can cross this CTO, not cross this CTO, but I think there is a pretty good algorithm in the coronary side. I think even on the peripheral side, there is an algorithm where you can look at the caps of the proximal cap and the distal cap and decide which option is probably the best option to choose. Like there are 4 kind of CTO caps. The first CTO cap we normally talk about is a concave cap on the top and a flat cap on the bottom, which is most favorable one, where you can just access it from above and cross it nicely cross from below. That tells you that the fibrous nature of the proximal cap is not bad, and the distal reconstitution is just a subtotal CTO. The second one is you have concavity on the top, concavity on the bottom. It's like an X-shaped lesion, which is also very favorable, but there is fibrous cap on the top and on the bottom. So once you cross the proximal cap, crossing the bottom cap will become difficult, but much more favorable to do it from antegrade approach. Now, there is the third cap, which is a kind of a complex cap, which you have a convexity on the top.
You have this Raman in your lecture? You know what? Raman has got this.
Okay, so
exactly.
So basically going, yeah, okay, so I think
caps. So hold on a second. So you're going to look at the caps and you're going to decide. But I think my question more is, see, all that stuff really hasn't been validated.
Yes.
And we talked about it just a little while ago offline. I think that this personal experience, and I think it adds a lot to our approach to these cases. But without validation, it's very hard to take that as dogma. And I think the coronary stuff has been validated very much over and over again. And I think that's important to tell the audience. But I think here, what I was really looking for is really trying to understand, because there's this push towards getting pedal access to try to cross these lesions. And what I want to really stress to everybody is that You can follow the CTOP classification. You can do whatever you want. But I think what's important to remember is really look at some of the predictors of failure, which have been consensusly agreed upon in numerous conferences, but really have not been validated. So a couple of things you can really agree is severe calcification or flush occlusion. I think most of the people who do a lot of these would agree that if you have a severely calcified cap or a flush occluded cap, you'll definitely have difficulty crossing, in any direction. Second would be if you have a cap with a flush occlusion with multiple side branches like you have here. So here you have a cap that's flush occluded with multiple side branches. Other than that, honestly, I think that the reason to come distal antegrade, retrograde access through the pedal is really zero in our practice. But I still think you should have an opportunity to try the regular antegrade approach prior to going distal. But we have a lower threshold of getting pedal access just to cross in these lesions, not to treat. So Robin will go over the CTOP classification in a second. So now that we talked about access and approach and some predictors in our experience of not succeeding, tell me what wire will you choose? This is another controversy. Do you go with an 018 system? Do you go with an 014 system? Do you go with an 035 system? And I think if you talk to different people who are very experienced, they believe in one system. So I'm curious on our approach and how would you guys make that decision? Again, we'll start with Vishal.
So, it all depends the anatomy of the proximal cap. So if you have a favorable cap and an entry point into the CTO, then I would probably just be aggressive enough and go with an 035 stiff glide wire, whether angle or straight, depending if you have an angle catheter, you could use a straight stiff, or even you can use an angle glide wire. If it's a flush occlusion and you really don't know where the ostium is, I'm not that aggressive enough, so I try to wire with a 014 stiffer coronary wires, like the CTO wires, try to get some traction. But remember, whenever you try to pass a stiff catheter over an 035, the 035 wire will keep popping into your collateral, So just trying to find that hinge or trying to find the wire to latch onto the CTO. I'll use my 014 or 018 stiffer wire to gain some entry or pretty much drill into the CTO and then exchange for an 035 wire and then advance to it. So usually an 035 with a favorable beak, otherwise start on a lower caliber and then go up as required.
Karthik and Sardar?
Vishal mentioned a very important point. Here you have the collateral, a very strong collateral, essentially supplying a lot of the distal part of the thigh. So you don't want to destroy this collateral by dissecting with a 035 wire directly there. If you identify a cap, which I believe there is, there might be this one exactly, might be the cap of the CTO. From here, you can actually go with a 035 wire, glide wire, or actually try the approach of Vishal with a 014 wire. Both approaches are feasible, actually, and doable.
Karthik?
I always start with 014 wire. So no matter what the cap is or everything, I just if I know that it's a long segment lesion, then I know I have to be aggressive enough with an 035 wire. I think for me, I think cap matters. Definitely a collateral like this matters, but I think calcification definitely matters a lot. The length of the lesion matters a lot. But I think here, I would definitely go with, I always start a cap with 014 wire and then decide if I have to escalate. I always escalate the wires, 014 to 018 to 035. But here I would definitely start with 014 wire.
And the reason being?
The reason being, again, it's my technique to always start with the 014 wire, but definitely here, because I don't want to dissect the collateral, especially that collateral. And even if you're in that cap, I would not still use an 035 wire because that might be a cap, but if the 035 wire, there's a high chance of perforation of that small branch if you use an 035 wire directly there. I think 014 wire gives you a chance, even if you perf, I think 014 wire gives you a chance to recuperate and make sure that you can contain the perf. This is a mid-type perf, so if you can, I'm sure we can cross the CTO, but antegrade or retrograde, but I would definitely try to avoid the pain for the patient if it's possible. But the risk of perf is high.
Okay, but I hate to be a naysayer here, but honestly, why do you give a poop about that collateral?
Right. The other collateral is more significant.
I mean that collateral doesn't supply anything. So collaterals become important when what supplies the lower limb, right? So when this is why the initial angiogram is very important, as you all know. So you see the initial angiogram, so you're looking at the occlusion, you're looking at the profunda, and you're looking at how the distal SFA fills. If you have an SFA to SFA collateral and that comes off at the level of your occlusion, then that collateral is significant. If you don't have an SFA to SFA collateral, and in this case, in the runoff, that's why it's very important to perform good runoff the way Raman did here, or Sardar did here. You can see here that you have a beautiful collateral via the geniculate to the distal SFA. And I am on a hypermag view here. I'm on a hypermag view here showing you the cap. So you already know that this collateral is insignificant. So yes, you can perf it by getting into it. I agree with that. But I don't think this collateral has any value in terms of any sort of significant blood supply that's going to cause any pain to this patient. As you know, we often close collaterals in the SFA when we do it. And we always are careful about the distal genicular collateral, which causes if the stent goes down, is going to go ahead and keep the leg open. But this collateral is not doing anything. So to me, yes, it might be supplying some whatever muscle fibers, but I'm not concerned at all in this collateral. I do agree with your other point that the 014 wire gives you the ability to torque properly, gives you the ability to be,
contained.
Or just, I don't think you're going to perf. I just think refined in your approach, because with an 035, you're going to be a big bully. So, I think that the other technique that Raman recorded here also shows that what Vishal and I did, we were able to track the catheter. We were able to find the little collateral. You can see there's a little branch that comes off. There's a little stump, and then there's a little segment, I don't know how you can see it, that comes off. And that segment is likely what's going to be it. So I agree to get into that, you probably need an 014 wire, but you can probably do an 035 as well. So, I mean, I think these are great points, and I think it's important for the audience to see. So again, I guess to summarize, as far as access is concerned, everybody in our group, which is a very busy group, feels that antegrade is probably the best access here. Some consideration to pedal access as a mode of crossing if we have any difficulty. Really no consideration to radial because of lack of length of modern devices, I would say, other than just available bare metal stents that may reach this. And also, and antegrade access is reasonable, but although we feel it's probably not necessary in this case, like Vishal said. To summarize in terms of our wires, I think it's, you heard the discussion, anywhere from 035 to 014 to 018 is acceptable. But here, I think, like Karthik said it best, it depends on the cap, and Vishal said it as well, how you want to penetrate the cap. So what wire should I choose, guys? I'm going to let you guys help me do this case. What are we going to choose? What
it's a dealer's choice.
I would start with a command wire if you're choosing an 014.
So, all right, let's go with the command wire.
I think
for first time, Sardar agrees with us.
Command wire it is.
No, it was PK. So PK gets an 035 straight up down start.
In my hands, this will be an 035.
See, I'm telling you. Me and Karthik will always do an 014.
I always want to learn from Karthik and Vishal. Always.
No, I mean, this case, Karthik, everybody is right.
Everybody's right. I agree.
So in this case, you could go either way.
PK, I just wanted to say, I mean, definitely you said this collateral doesn't matter. But I felt like this collateral matters of what you want to do. I think if you have already decided to stent it, I understand that. But if you're not deciding to stent it, this is an SFA to SFA collateral. If you see
it's not,
this collateral,
it's not. Look at the runoff. The runoff shows
the other collateral is more significant than this.
The profunda collateral comes to the P1 segment, but this collateral forms gives you the Hunter canal segment. If you look at it.
But both. Even if you close this, the distal collateral will
go.
No, that's true. That's what I'm saying. But if you're planning to just do a DCB,
it doesn't.
Okay.
It doesn't. No.
I think it doesn't. This one doesn't.
Okay.
We love to argue with.
But you're right. I mean, it's the common thought process is correct to save the collateral.
When I see that big of a collateral, I prefer not to lose it.
Yes.
So.
No, that's what I'm saying. The thought process is correct.
With you, but I mean, if you look at this cap, can you show the cap again? If you balloon angioplasty that cap, you're going to lose the collateral, even if you DCB it.
You think so, PK?
I think so.
Okay.
I think you have so much plaque in that cap that you're going to lose the collateral. Your potential is very high. It's sort of like the coronary situation. Look at the size of that. Look where you're going to balloon angioplasty.
Yeah. Right.
Well, it'll be a delayed filling collateral.
So what do you think is the reason you may perf here? Because I agree with you, because I think
It'll
that,
go into the
this we
smaller.
may
The
be the
re-
collateral here.
Yeah, the reason I think we might perf is I don't know if this is really the cap. I mean,
Correct.
it is possibly the
Exactly.
cap, but I just don't know this is a cap or not. Because it's a very blunt cap, so it's possible this is a cap. I mean, that's the only thing we have option as to try.
Right.
But I think
That
there might be a completely separate cap. This might be completely a flush occlusion.
So I think that's where Karthik's point is great. So if you're not sure if it's a collateral, it's a cap, it's an underfilled segment of the SFA, then go with an 014. The harm done is much less as compared to going to an 035 and then dissecting and hematoma and you're in the muscle or wherever. So an 014 won't cause you as much trauma
Oh, that's not
if you're
bad.
not sure.
Okay.
You like
No,
you
it's-
like that?
No.
I don't know. I mean, probably take a different angle and say, I think you slipped into the big collateral, but
Yeah.
Now it's correct.
now
Yeah.
it's correct, definitely.
Yes, that's it.
That's better. That looks very favorable, right?
See, but this is the poo-poo that you go through with an 014.
Yeah, yeah,
See this?
yeah.
This
No,
is
but
such
if you-
poo-poo right now. This is
Confident.
like, I'm not joking.
if
This
you-
is so annoying.
If you
Who said that?
PK,
continue.
PK, I just
No,
wanted
no,
to say,
I know. I agree with you. I'm just saying I adjusted it, but look. The damn. See, now I loop again. Man, you know,
Yeah.
give me my.
There you go.
Give me my straight.
PK, I would
I-
definitely show my son this recording because you have said poo-poo a lot of times in this recording. So he would love to hear that word. So
We can actually say now everyone was right, because now we identified that this the proximal cap, the real proximal cap,
Yeah.
with the 014 wire, and now we're gonna go with the 035 one.
Everybody's happy.
Everybody is right.
Oh my God, you guys. No, but so anyway, so this is important. So I think these are great points. As much fun as we're having, this is a great point. And see, the reason I decided to go with the straight is, it looks like we're in the right spot,
Correct.
and we lost our pressure. Where did we lose our pressure?
Yeah, because,
Oh, because we took it out. Okay. Flush forward, Michelle.
Mhm.
Give me a syringe.
Aspirate back.
Sorry about that, guys. A little technical issue here. Got some clots.
So, Sardar, just to
Yeah.
let's continue our discussion here. But when would you go for a retrograde access here?
See?
I mean, in this case, initially I thought that the proximal cap doesn't look favorable, but doing the extra high MAC pictures showed that the proximal cap is actually very favorable. I would never actually start with retrograde. I will always have an antegrade access. Because even if I go retrograde, I would just do it for the sake of crossing, and but the procedure will be completed from the antegrade access.
Right.
So, if in case I escalate the wires and don't
Yeah,
find
magnet.
into the cap and not
roadmap.
able to cross, I might escalate towards a pedal access, or maybe in this case also distal SFA access.
Distal SFA access
Might also be an option.
That's a good option.
That's
And
a good.
then-
Yeah, it's true. We never talked about this SFA.
Distal SFA, also, yeah.
Well, nowadays when we have this pedal access, then I don't know how much distal SFA access you really want to get in through the thigh with the pain and everything. I think you can cross through retrogradely and then work up and over, so that way you can save your distal SFA access. I would probably.
Vishal, would you use a primary pedal access here?
Okay, give me.
No,
Give me.
I mean not really
angle
unless we
glide.
don't have to.
Angle
Angle
glide.
glide. So the
PK,
straight glide.
PK, I know if you take the same 014 wire, I know you said it made a big loop and everything.
Okay,
But if you take
Give me a confidence.
but
No, no, we
instead of
have it.
instead of using 035 catheter, right? If you use an angled 014 catheter and go forward with it, right? Do you don't think that will be a good idea to do it? Your
But,
trackability will be better. There's some calcification.
No, the trackability is good. I can definitely push it. I agree with you. If there's no trackability, we could do that. But for me, the point is like, I always tell the fellows, is the juice worth the squeeze, right? Like, what are we doing here? We just want to connect the dots here. There's no data that shows that intraluminal is better than not being intraluminal.
That's
There's
true.
no data that
That's
shows
true.
anything. For me, time is important and safety is important. So safety first, obviously. So in this particular case, if the way we're going, I think it's more important. See, we're in a bad spot here.
We're in a bad
So I'm just
spot,
going to
yeah.
rotate the catheter. But I think that's very important here. To really
So I'm
decide
saying
where we're going.
if you
Branch.
why don't you restart your loop on the top,
Yes.
PK?
I agree.
And then
I agree.
yeah. So I knew you will say time is important. That's what I was trying to get to. Is so because you're talking about pedal access here. So
That's the calcium.
a lot of people who are watching it might be
Okay, right in the
thinking,
calcium. Fine.
And
you
then
know,
it goes around.
I'm not going to spend so much time trying to do antegrade. If I go pedal, I might be able to cross this in probably a couple of
Well,
minutes.
it's in the.
Really? I doubt it. Not with this much calcium. I don't agree with
That's
that.
what that I'm trying to be devil's advocate here. That's what I'm thinking. A lot of audience
Okay.
will be thinking
Yeah.
who practice pedals. They always think people who
Yeah.
practice pedals
Little
always
okay.
think it's much
No
easier
doubt.
to cross pedally than antegrade. What do you
Follow.
think about yourself?
Yeah.
I think it's if you do enough of CTOs, you
You're right.
might choose the pedal access as your alternative access. But I think completing this procedure from pedal is
I think I have to
just unsafe for the pedal arteries. I would use the hybrid approach and start antegrade, and if I escalate and we are not successful, definitely for the sake of crossing, get a pedal access and try to cross.
Okay.
Once I
Stiff
cross, I switch back to antegrade access and snare the wire out and floss it out, and
not gonna
then complete the
Yeah,
procedure from
break a stiff
antegrade.
angle.
Give me the Terumo M wire. Now I'm going to switch to an
That's-
018.
Thermal gold.
You can always go back up and restart.
PK, how long would you give before
Command
you
is
switch
fast.
to a retrograde access?
Probably 20 minutes.
Okay. How much do you use?
I mean, it all depends on.
Yeah, all depends on progress.
It's very hard to say. I wire 20 minutes and then I just change.
I agree.
It's very very frequent. You have a feeling due to your experience whether you're gonna be successful with one or the other wire. Then you escalate the wires, and finally, if it might happen after 5 minutes that you say, okay, I'm done with my antegrade alphabet, and now I'm getting retrograde access. This might also take you up to 25-30 minutes, and then, but definitely for the sake of the radiation safety for the patient on your team, you can you should escalate to an retrograde access. Definitely not more than 25-30 minutes.
Vishal, do you switch quickly or?
Well, it depends when you get frustrated. I guess that's the right answer. So, but yeah, I mean, if you lose all your options, your wires, you created a big subintimal dissection plane, hematoma, you're not able to enter, then you just like switch over. But
So
I don't think there's a timeline. It's just when
there
you start
is-
thinking, you're losing a battle.
There is a question from the audience regarding the selection of the 018 Terumo M
that's it.
wire, Dr. Krishnan.
Yep.
What was your reason for selecting this wire? Was asked from one of our watchers.
Just experience. I mean, to me, I think, this wire, you can see it's torqueable. It gives you enough body. And now I'm going to switch to a Terumo Navicross because you can see the heavy calcium we're dissecting all the way down. So give me a Terumo Navicross, and I'm going to go down with a Navicross.
PK, you
Get
think the
close.
direction of the Terumo M is good?
I think right now it's acceptable. So what you're doing is you can see you're in the calcific plane, and that's part of the reason why I felt like 035 would be better, because you are going to get subintimal in this kind of lesions. But I think at this stage you're close enough to the cap where if we, like Raman was talking earlier about using a re-entry device to demonstrate that, I think it actually may work. But let's see. Let's get close. Navicross, please.
I think it's an RAO view as well. So just to keep that in mind. So
Yeah.
I don't know if you can see, but yeah.
Yeah.
But it looks favorable next to the calcium. We're subintimal.
Yeah. So
but
give
see,
me a roadmap.
yeah. Hold on. Okay, go.
So I think the wire was swirling around the whole calcified cap. So you can
Exactly,
see it.
and that's
Yeah.
what happens, And if you get a little perf, don't worry about it. I mean, it's not a big deal. See, we're heading kind of toward it. You can see the wires heading toward it, so that's normal. And you're just gonna have to deal with it. I mean, this is a situation where you'd like to get in, and once you cross, we'll talk about algorithm of what we do. So right now, while I'm working, I'm asking our AV team to put this on the side, and I want Raman to go over this nice lecture that he's prepared, talking a little bit about everything that we've talked. And Raman, I want you to stop right before treatment.
All right.
Okay? Great, I got wire. Go ahead.
Hold on one
Can
second.
you put up Dr. Sharma's lecture, please?
Good. I got it.
You got that?
There you go.
Okay. So next slide. So as we were talking about, as Dr. Gujra had mentioned, there are different calcifications and morphologies of the proximal distal cap that become very relevant as far as describing the amount of that can help guide what approach would be best suitable. And you see on the bottom left the 4 different diagrams, 1, 2, 3, 4, from left to right, showing the concave and convex entry and distal caps, and each of them, as you go from 1 to 4, demonstrates an increasing overall complexity, where the type 1 and 2 could be fixed, and a successful procedure could be accomplished by just a traditional either contralateral or antegrade access, versus 3 and 4, just by the nature of the proximal distal caps, may require a retrograde access to achieve success. Because as you can imagine, when the proximal cap is not very favorable, it's very easy to not it's very easy to have a very challenging time engaging the proximal cap, and always going off into collaterals if there are many significant side branches,
I think it's true.
and never really ultimately entering even the subintimal space. So again, all these, the ones in which we've been discussing for whether or not a hybrid approach with an antegrade and a retrograde access would be appropriate would be a type 3 or type 4. Next slide, please. So this is one of the previously published algorithms for how to intervene upon CTOs. That was developed by the PCTO group and presented at TCT. And it kind of demonstrates a similar treatment algorithm than we have all discussed, but everybody has had somewhat of a different opinion as far as how to really proceed. And I think the one real main takeaway from here is that there is no gold standard as far as how to really do this, but as long as you have a systematic approach and you continue to try to assess what would be the best as far as the best access point for each particular lesion based off the proximal cap, whether it's blunt or ambiguous, what is the length of the actual the CTO segment, do you have a good target vessel? And then the question would be, which would be the best way to really go? And in this particular group, they had a characteristics of 4 things, which was either a blunt ambiguous proximal cap or a type 4 CTOP classification CTO lesion, as well as a suboptimal target vessel, appropriate distal vessel access, and a CLI patient. So in this particular approach, they had suggested that a retrograde access would have allowed them a good amount of success in the procedure. And again, the retrograde access also then requires, true lumen puncture of the distal vessel, and then again your possible need for your more advanced cart and reverse cart therapies to then complete the actual procedure. Next slide, please. So we have a lot of re-entry devices available in the market. We have the Outback and Pioneer, which are the 2 main ones that we use here in this institution. The Outback is a re-entry device that works off a fluoroscopic guidance with 2 configurations of a distal fluoroscopic marker that in one view should be an L, and then in an orthogonal 90-degree view from that view should be a T configuration. And then there is a 7mm needle that can be advanced to gain entry into the true lumen. Pioneer is a very similar concept, except this uses a IVUS guided design that allows you to actually orient the true lumen that you're trying to gain access to, rotate your device to 12 o'clock, and then where you find the pulsatility of the actual vessel, that's where is the true lumen. And by a marking system on the actual IVUS, you can gauge directly how much you have to advance your needle to gain access to it. The N-tier is another flat balloon that has a needle that is directed towards the true lumen, and the off-road is another similar re-entry device that we particularly here don't use as often. But again, it's a conical balloon that, when it's inflated, has a distal part of it, lean in towards the true lumen. Next slide. So this group published a paper in the Korean Circulation Journal that kind of looked at what was the utility of using manual reentry versus a reentry device in all these CTOs. And one real simple takeaway is that success happened regardless. The difference was that what it really did affect was the amount of time needed on the procedure, the fluoro time, the time of actual reentry, and contrast use with the reentry devices. And that's really important to kind of take away when you're considering, as these procedures, some of them can be very, very complex. What is the true, harm to the patient, as and using all the contrast and all the extra fluoro time. So it's something to definitely keep in the back of your mind. They also had another analysis looking at the Outback versus the Pioneer reentry system, and again, both of them did quite similarly. But the main difference was that the Pioneer group, again, to keep in mind, this is quite a small registry of patients. The Pioneer group had a little bit of a less time required for reentry, but again, with IVA's guidance, it does make the procedure somewhat more manageable. Next slide. Finally, we can be talking about some crossing catheters. We have a lot of these catheters once you're within the true lumen. And basically, there's a kind of ways to just grind through the true lumen, whatever it is that may be causing the actual obstruction. The one that most commonly used here is actually the laser made by Spectranetics, and this basically has pulses of the ultraviolet light to basically just either ablate all of the calcium and to allow for forward progress through very challenging and heavily calcified CTO segments. Next slide. All right.
Pioneer, do we have Pioneer? We should have one.
Continue on to the therapies, or?
No, this is good.
Yeah.
So right now you can see that I want you guys to see the staining. I don't want you to get scared of that. I mean, it is a CTO. We're in a dissection plane, and it's funny. I don't know why we've gotten so much staining, which is kind of interesting. So at this stage, what I want you to do is to say to yourself, okay, now we're not able to get through, and now I'm going to go ahead and do something else rather than keep trying the same thing. So it's been 10 minutes of wiring. For me, it's a claudicant. I don't have any reason to go pedal access. Very diseased distal vessels. So I am going to go with a reentry device that we decided. Give me a particle wire, Chief. So what I'm going to go here is go with an Outback, which I prefer the Pioneer here because of the calcification, and I think we're on top of the vessel, but I like my current position a lot better than I like my last position. You see how the wire, how my catheter is more parallel to the vessel?
No, Spartacore.
Spartacore. So therefore, that will help me to be very clear in terms of how I'm going to enter. So go ahead.
Dr. Krishnan, a question. Just for the audience who were watching while Raman was giving his presentation, you changed for 035, 018, and then I believe there was a Confianza wire as well, or?
Yeah, I tried a Confianza because I felt Vishal and I were looking at the vessel. We felt we were on top of the vessel initially, so we thought we could pierce down. But clearly here we're on the side of the vessel right there. See, that's pretty good right there. I'm happy there. So I'm going to walk this back, and then I'm going to go with the Outback catheter. The nice thing is we have a nice favorable arch. The Pioneer would be better for us, in my opinion, because the ultrasound would help us because we're pretty much above the vessel, I believe.
And also it's a big vessel, so you might get a good color flow into that vessel.
Exactly. Totally agree. But unfortunately, we don't have one on the shelf. We've been doing a couple of deep venous arterializations over the last couple of days, and we've used a lot of the Pioneer catheters. So we don't have any Pioneer catheters on the shelf. So right now we're going to go with the Outback, and we'll see what we can do. Damien is going to be kind enough to ask one of our techs to check in radiology if they have a Pioneer catheter for us. Okay, they're looking downstairs. So as we speak, in case the needle is not going to be long enough to pierce the calcified cap. So now I'm going to go with this catheter. We're always going to have resistance as we let go of the wire a little, please. As we go over the arch, perfect. So you always want to let go of the wire a little bit as the operator tells you to. You want to get it down there. I don't know if it's going to go. Let's see. It doesn't seem to want to go.
Yeah, you might have to balloon the track.
Might have to balloon the track. I was hoping that the 035 wire catheter went.
I think it's because of that calcium in the mid
yes,
segment
I agree, buddy. I agree. Yep, and we're going to destroy this. So walk this out. Damien, give me a 4-0 balloon, buddy.
So you think you're right on top of the vessel?
I think so. I mean, it looks suspiciously close to that. So we're going to go with a 40014 balloon, and then we'll go ahead and balloon it, and then we'll do it. So right now we've turned off the Angiomax, and just to see while we balloon and see where we are.
Okay, now you should have it.
And make sure.
Yeah, I mean that's the biggest issue is with these re-entry devices.
400 is fine.
This is actually a very good case to see how challenging it can be to cross and to
so PK,
put your devices
your
there.
PT segment, your posterior tibial segment is a very short segment, right, of CTO. So you don't think if you access the PT and go from below, I'm pretty sure we can cross the PT much easy, and because it's a CTO segment anyways, you don't think that will be a good idea to cross it from below?
I mean, I'm not saying it's a bad idea. I just feel that you're treating this guy as a claudican, right? And I think to cross to 2 CTOs to treat a claudican when you can open an Outback catheter and be done with it. These catheters are now very cheap. We're getting the Outback quite cheap now, and the Pioneer very cheap. So I don't think it's that much of an expense that you're adding to this case.
Okay. So only that staining, the staining is a little concerning. I don't know why the staining
is concerning.
I don't know why there is so much staining at that point though. That's after the distal cap. So
yeah, because it's tracking down. That's all.
It's tracking down. No. Yes.
Okay, let's go up here. Show me off-road map here.
Off-road map. So Karthik, why not the 80?
Okay.
Because
the only reason is because he's a claudican. So I don't think we need to destroy a vessel which he regularly. I mean, it's.
Let's go up here.
If you do a sheethless, like we usually do with a support catheter, and we get access to the AT, I don't think we'll cause enough trauma just to cross it. And then, like I said, you can work from the top, snare, whatever you want to do. But just crossing.
The only thing is there is so much calcification here. You have to really. There needs a lot of pushability on the catheter. So when you're pushing the catheter back and forth, you can cause a lot of spasm in the vessel itself. So I just feel like there is no reason to take a chance with the vessel he has, which is not a regular vessel. His AT is disease too. So, so I think the PT segment is very short and favorable for us to go through. So, but again, 14. As PK said, he's a claudican, so there is no reason to cross 2 CTOs. That's a reasonable option.
Little die.
It's what chance do you want to take with it? That's a question, and it looks like it's a nice channel we created there.
It's just a dissection. That's all.
Yeah, it's just
yeah.
Okay, let's walk it down. Just walk it out.
Yeah.
Is there a Pioneer available or no?
No.
Is there a Pioneer available or no? I thought we had one. He said we had another one.
Yeah, because we had one for the next case.
But there isn't.
They used for last night. They haven't run for this.
Who used for last night?
So.
Yeah, I was here Monday.
Yeah. No, but we had one for the next case.
For this reason.
I think Outback should be fine, PK, because the tracking looks like.
I'm sure it is, but I'm just saying that I don't understand why, when we thought we had one, we don't have one.
I mean, it happens when you do. We are doing a lot of cases after COVID, especially critical limbs. So I'm sure we ran out of equipment, and because of the COVID, I'm sure the hospital is not getting a lot of equipment coming in. So
that's true.
That's true.
I think it's a national problem. Yep. Everybody's facing it. So.
Look a little bit.
It's a new normal, so we have to get used to it. So
good, fix it there.
Even though we pride in Mount Sinai that we have everything on the shelf, it's a new normal. I think we have to take
Damien, give me a new Sparker. Just keep it on.
No, I need a fielder.
Oh, he wants a fielder. All right, so I remember Dr. somebody asking me. Yeah, sorry.
I think so. You exchanged now. You want to exchange for a fielder, just for the audience. Why did you exchange for a fielder rather than Spartaco?
Just to cross.
Okay, so somebody asked me this question, which I guess does make sense. So if you're using fielder, which is a hydrophilic coated wire through a needle, would you not shear the coating off? I mean, that's the normal thought process.
I think definitely you're right. You can, but I feel that the fielder is able to get through some dissection planes that you might have created.
So PK, if you don't mind, Sardar will probably start going over the Outback technique you're using while you're trying. you want to go over?
No, actually, so Dr. Krishnan placed the outback catheter. He took the Spartacore wire out, exchanged it for now, and then he pulled out the needle. If you see it, it's on the right side of the screen, next to a little bit above the L radiopaque marker. Now you see the wire coming out of the needle. Looks like could be short.
So PK, so when you are getting in with the needle, normally you want to be in a T shape to the vessel. Then you turn it to an L shape, and then you start releasing your needle in. So I think PK already knows which direction the vessel is, and normally what you have to do is you have to put it in a T shape like this and take a picture in two angles. In one angle it has to be T, in the other angle it has to be L. The angle which has to be L is the angle which is right on top of the vessel or parallel to the vessel. So I think PK already knows which direction the vessel is in, but so now he's changed it to an RAO view.
For the teaching purpose.
For the teaching purposes, I think he's doing it.
Well, for me, I'm a little concerned because